Good morning, everyone. I'm Dr. Randall Maxey. I'm joined by my two, soon-to-be three co-moderators. Dr. Barber, would you give us an introduction, and then I'll lead off with introducing our new addition to our group.
Certainly. Good afternoon, everyone, and welcome to Black Health Trust. We are once again having the opportunity to gather together to talk about COVID and other health issues affecting the Black community. Today, our topic is a general topic of what's going on relative to COVID in the Black health community, and we look forward to answering your questions as we proceed with the program. I am Barbara Neighbert Stevens. My co-moderator is Dr. Ivan Waltz, and our founder is Dr. Randall Maxey. Dr. Maxey, take it away.
I don't know if anybody can hear that sound. Is there a sound interrupting us?
There's a sound in when you're talking, Dr. Maxey.
Okay. I'd like to introduce our new addition to our group. And we're joined by Dr. Jocelyn Hines, who's a board-certified family medicine doctor. She's been in practice for more than 15 years. She's been caring for patients of all ages, doing primary care, urgent care, emergency care, and occupational medicines. She currently is the medical director of the Invalon group.
Dr. Maxey, it's really hard to hear your audio. Every time you speak, there's some feedback that's coming through.
Okay.
I don't know if there's any way that you can clean that up.
Of Dr. Hines.
I will try to go ahead and do the introduction, but we can let Dr. Hines introduce herself and tell us about what she's doing and what her background is, and that might be the most accurate.
Sure. Thank you for your time this afternoon. Again, my name is Jocelyn Hines. I'm a board-certified family physician. I've been in practice for over 15 years, and I've done primary care, urgent care, ER, occupational medicine, seen patients of all ages, practiced in various places around the country. I spent several years doing locum, so Indian reservations, federally qualified health centers, urban environments, caring for all ages. Currently, I am working for Inovalon as a medical director doing healthcare analytics work. And I am enjoying that space and getting to see the other side of healthcare from the kind of insurer side. I'm also the president of the Maryland Academy of Family Physicians, where our goal is to support and promote activities that improve the health and well-being of all our communities. And thank you again.
And I will just add that Dr. Hines wasn't satisfied with just being an MD, so she also has an MBA. So she's one of those smart people that that continue to go to school, and also brings a voice that's just a little tiny bit younger than the rest of us who are moderators here at the Black Health Trust. And so we really appreciate her joining us.
A great bit younger. So I hear MBA stands for More Better Advocate. So welcome to us, Dr. Hines. I listened to a TV station today, and I was very amused, shocked, PO'd at listening to the governor of Mississippi try to answer a question posed to him by the host. And the host asked him a question related to the fact that the state of Mississippi, if it were a nation, would be the second highest COVID death rate in the world. And he refused to answer that question. He simply wanted to be free from the edicts of a tyrannical current president of telling him what to do. but he expressed no concern whatsoever of the increased death rate from COVID and from the variants of people in his state, no matter whether they were black or white. He just had no truck for it. And I believe that is the general outlook of certain states, especially those that are so-called conservative states or red states. And I think that is a concern, that whatever they can do to lessen the health success of those communities in general, but especially communities of color, they will do. So in my way of thinking, I view this as an active war against communities of color. And I know some of my colleagues don't think that may be true, but I look at this as an enemy, and the enemy is somebody who will shorten your life, make your health worse, and even more than that, affect the people that you know and love. We want to go on, and not going to have a bunch of lectures today, but we are going to talk about the same topics that we want to put under common sense. And we titled today's talk, What's Going On? And I'd like to start off with our statistics from Dr. Nabert, and like to introduce Dr. Hines, and let's have a discussion, rousing, if you please, on what's going on in our country and the world. Dr. Nabert, will you tell us about our statistics?
I'd be happy to. And today I'm going to give the usual, but some additional ones, because I think rather than just rattling off statistics every week, I think we need to start really talking about what these statistics mean. And that will help, I think, in the framework of the rest of our conversation. As usual, our data source is the CDC, updated as recently as yesterday. The total US cases since the beginning of the pandemic is 41,915,285. Now, of this, 12% is made up of Black and non-Hispanics. The total new daily cases reported as of yesterday were 154,513. The total US deaths since the beginning of the pandemic is 670,565. To put this into some perspective, I'd like to deviate from our usual pattern and refer to an article that appeared in the Washington Post 4 days ago, where they took the CDC data and put it in a different framework. So of that huge number that I just mentioned, 670,565 deaths, 14% of those were Black or non-Hispanic. Of all the age groups in the Black non-Hispanic demographic, that represented 1 in every 480 African Americans have died from COVID since the beginning of this pandemic. And I thought that was very chilling. And I wanted to bring this forward today. And for our young audience who think they are invincible, in the 18 to 39 age group, 1 in every 4,900 African Americans in that age group have died from COVID since the beginning of this pandemic. Now, of our total US daily deaths as of yesterday, that was 2,087. Since the initiation of the vaccination program, there have been 384,911,290 doses that have actually been injected into somebody's arm. Of Blacks, non-Hispanics who have received at least one dose, that is 10.4%. of Blacks who have been fully vaccinated at this point is 9.9%. As I did last week, and as a pediatrician and a parent, I'm very concerned about what's going on with the kids. And still, this data is very difficult to get because of reporting habits of the different states. But based on the information that the CDC has been able to get, up till now, in the age group of 0 to 4 years, there have been 774,864 cases of COVID, and there have been 176 deaths. Of the 5 to 11-year-old group, there have been 1,579,294 cases, of which there have been 109 deaths. And of the 12 to 15-year-old group, there have been 1,331,279 cases with 143 deaths. Don't let anybody tell you this stuff is not real. That ends my report.
I'd like you to make one other quote as a part of your report of a comedian you told me about.
Oh, yes, my favorite comedian, Chris Rock, tweeted out today that he has COVID and nobody wants it.
Well,
And do get vaccinated. The end of his tweet was, and do go get vaccinated.
okay. We're going to hear from Dr. Ivan Walks and Dr. Jocelyn Hines, but I want to give just a few minutes of what I call disease 101, as I see it. And I may take a little bit of poetic license. We know some of what COVID does to the body and the spirit. Well, one of the early scientific things that we found is that the COVID gains entrance primarily through a set of receptors in the body called ACE2. And those receptors are an entry point of something called the endothelium. What is the endothelium? The endothelium is a layer of cells that lines the inside, the innermost surface of every blood vessel in your body. Why is that important? If you took all of those cells and laid them out end to end, touching each other, even the smallest person on this call, it would take up the square footage of 6+ tennis courts. So it is arguably the largest organ in the body. And imagine that this organ supplies your heart, your brain, your kidneys, your feet, your knees, and even some of us call it the last nerve. I don't know where that is, but some of us have something called the last nerve. So this endothelium is extremely important. When it gets sick, it can be devastating. For example, I talked to a friend of ours, Dr. Roger Mitchell, who at one time was the chief medical officer of DC, the coroner. And he said that in all of the autopsies he's done on people dying from COVID, they had blood clots in almost every organ and every place in the body. What controls those blood clots? The endothelium. So an unhealthy endothelium can affect your brain, your heart, and everything else. What else can it do? We know that people with diabetes, the main damage of diabetes, or the so-called sugar, the elevated sugar, is to the endothelium. And it promotes blood clots when it's unhealthy. It promotes cholesterol plaques. It can lead to heart attacks. When people have high blood pressure, the same thing can happen. If you get my drift, this is the final pathway that tends to lead to health and bad health and destruction for communities of color. In many cases, not eating healthy, not using antioxidants, not using the vitamins that we need. We talk about vitamin D and vitamin C. Again, that has a major effect on the endothelium. So what I'm saying is, it is good endothelial health that can help you resist the ravages of this virus. And almost everything anybody can think of in people who get sick from the virus, whether it be their low immune system, whether it be high blood pressure, diabetes, obesity, it has to pass through that endothelium to really do the damage. So as we talk about these various things, the endothelium is something that we need to strive to make healthy, especially in view that so many people have recognized this Achilles heel that Americans of color generally have problems with that endothelium, some of which is genetic, some of which is environmental, some of which is dietary, and even emotional. And I'm a believer that post-traumatic stress disorder can also involve and invoke blood clots, plaques, and inflammation in that endothelium. And with that, I'd like to introduce Dr. Walks. And Dr. Walks, I'm going to let you lead up to our new star, Dr. Hines, who I'm very excited is with us.
So thank you, Dr. Maxey. I always like to take that perspective of just the regular person. Explain it to me so I can understand it. And I know I'm supposed to be a smart doctor and all of that, but for me, I always like to be able to understand things very simply. That's just the way that I think I can be a better teacher. If I can understand it simply, I can explain it simply. And what you just said is so important. I kind of think about it like how I think about the government when they talk about, well, this part is doing that and this part is doing that. Nobody cares what part is doing what. They really want the government to work. And I think about the human body that way. It's important that we understand from a doctor's perspective, all of the things about the endothelium and about the different organs and all of that. And at the same time, it's critical for us to use what you talk about, Dr. Maxey, as common sense of just doing things that make us healthier overall. You mentioned vitamin C, you mentioned vitamin D. I will add to that things like exercise, things like getting sleep, things like protecting your mental health. There are all of these things that come together to allow us to be healthier and to allow us as just human beings out there in the world trying to make it, to deal with COVID, because COVID is trying to get us, but all the other stuff that's trying to get us, the stuff you mentioned, Dr. Maxey, diabetes, high blood pressure, other things, everything is trying to get us. And so the better we can build a comprehensive guard around that, I think the better. One of the things I like about Dr. Hines and her wealth of knowledge that she brings to this is she can speak to things from several different perspectives. She can speak to things from a physician who is younger in her career than some of us. She can speak to things from a family practice perspective, dealing with families, which makes you have to deal with all that stuff, right? The physical stuff, the mental health stuff, I don't have a home, my kids are sleeping in the van with me. All of those things allow a family practice doc to think comprehensively about people when they come in. But the other thing that maybe Dr. Hines can bring to us that no one else on the call can bring is her immediate role as a leader in the medical community, heading up a statewide family practice organization. And maybe Dr. Hines, you can talk to us a little bit from a health policy perspective. How do you guys, as that kind of an entity, that group of doctors, think about impacting the community from a policy and a practice perspective? I know I didn't ask you to prepare to answer that, but it's just, we have you here and you have that expertise. And can you kind of bring what Dr. Maxey's talking about from the health of the individual to what do organized groups of doctors have the capacity to do and the interest to do that help us to build a healthier community?
Sure. So, for example, especially as it relates to COVID, when COVID first came out, right? So, as I said before, I'm with the Maryland Academy of Family Physicians. At first, the question is, and we're a volunteer organization. The first question was, how are we going to respond? What are we going to do for our members? What are we going to do for our patients, for our communities? So part of that even began with recognizing that a lot of our docs were frontline folks. Like we're getting slammed. The offices are closing. The patients aren't coming in. Who's the first target? Who are we connecting with? Are we trying to connect with each other, get ourselves on the same page? So to Ivan's point, one of the ways that, for example, in Maryland, we tried to deal with that is first set out some education to physicians, because even though we're physicians, we're not a monolith, right? So we don't all have one brain. We're not all accessing necessarily the same resources. For the folks who are just crushing it every day, 8 to 5, 8 to 6, 8 to 8, right? Seeing patients in their offices, in their nursing homes, in various community settings. They may not necessarily be keeping up with all of the news, right? So the first step was getting regular messaging out to our physicians, and then partnering with like the state and county health departments to facilitate things like patient education and patient education forums, and having open discussions. So we also would facilitate kind of town hall meetings, Zoom style town hall meetings, so that we could get to our patients, get to our communities, and ask them, what are the questions that you have? What can we bring? And we try to make a point of bringing people who are active in the communities that we are targeting or addressing with those town hall meetings. And what we found out was a lot of the questions that they had were not the questions that were being answered on the CDC's frequently asked questions page, right? Their questions were around things at that time around, microchips, and it was around things like long-term fertility rates and things that weren't necessarily answered with more information on how vaccines were developed or where did COVID come from. Those weren't the things that were kind of guiding some of their decisions. And we've continued to do that as an organization, as a physician organization, throughout this pandemic. The other things that as an organized group of physicians we're able to do is also lobby our legislators, right? So lobby our legislators to make some of the temporary rules that they've made during COVID permanent as it relates to how physicians can provide healthcare in virtual settings to their members, because we recognize that virtual access to care has improved the ability for lots of people, not just people who were homebound, but for lots of people to be able to engage with their providers. And that has in some ways been a bit of a benefit, because that's a barrier for lots of people who have jobs that they can't take off work for, or if you're a caregiver to kids, if you're a caregiver to other adults or family members, the virtual healthcare setting has been a way for those folks to at least get some kind of care for those things that can be addressed in a virtual health setting. So those are some of the ways that we try to outreach to the community and in an organized fashion. And as it relates to the overall health of the individual, certainly we've, again, commenting to educating your legislators and educating the community. We've had infomercials and commercials on just the importance of, while you're out getting fresh air, right, you can still exercise and things like that, because some people just stayed home and literally didn't leave their homes because they were scared. Well, there's a depression factor that comes into that. There's an obesity factor that comes into that. There's all kinds of consequences to a true lack of physical activity and a lack of just interaction, a lack of sunlight. We were talking about vitamin D earlier, and it's a 1.5 years later. So there are a lot of potential consequences to isolation, I'll say. And those are just some of the things that, as an organized group of physicians, you can target, because sometimes you need to target the physicians, and you also need to target the other healthcare workers, as well as patients. And when you do that, that by definition impacts the community around you.
So Dr. Hines, I'm going to ask you to get a little bit personal about this also, because as a doc who is also a parent, because Dr. Nabrit Stevens mentioned about being a parent earlier, but you're also a parent of kids that are too young to be vaccinated. So while we're running around talking about how everybody should be vaccinated, everybody from Randall Maxey to Chris Rock that says, get your vaccinations, you have to deal with the fact that kids are now going back to school. Your personal kids cannot get vaccinated yet, even though I understand they're asking you, Mom, when can I get vaccinated?
Yeah.
Tell us a little bit about how that struggle for you plays out in terms of what you do, so maybe other folks can figure out a better way to handle those questions from their own children.
Sure. So for context, I have a 6-year-old son and an 8-year-old daughter. And when COVID hit, they came home, right? All their activities pretty much stopped. And we did virtual school to the best of our ability, while I also tried to, which I call crisis school, because they're doing virtual school, I'm working. It wasn't like, oh, now we do homeschool. And my daughter in particular, she had a very hard time. I could absolutely see the mental health effects of that loss of engagement. Like we lost grandparent time, we lost friend time, play date time. And she's very much an extrovert. And really, it was just she had a really hard time with it. On the other hand, my son, in some ways, I learned things about him and how he learns and how he interacts, especially from a schooling point of view. And that part was actually a bit of a blessing. And we gradually, especially, over the spring and summer, started going back to some controlled outdoor activities, because I knew they can't just stay in the house, right? And when school started, so they just started school at the end of August, we were very, very well prepared. I mean, they've got masks on top of masks. They've got hand sanitizers. We have cue words for when they're supposed to, clam hands. So clam hands mean that the kids are supposed to do this, and that means don't touch anything. We're somewhere, we've gone outside and don't touch anything, because we've been doing this for so long. But there was I thought about, like, is it possible to not go back to school? And I had to decide that I think that it is better for us to go back to school. But our school system had a very reasonable COVID mitigation plan. We are in a place where masks are mandatory for school. All of the teachers and everybody with the healthcare system is either vaccinated or getting tested. So I was lucky enough to be in an environment where the folks, not just where I'm sending my kid and what I want to do, but my school system is doing things that I think are reasonable. And they were very transparent about making, the statistics known on what's happening, are there any outbreaks in school? It has been worth it to me to see the joy in my kids' faces, to see their friends again, and to engage, even though there is obviously still a degree of concern. But everybody has to do what's best for them. And for us, I felt like that was the best decision we could make for their long-term, for their education, for their social and emotional well-being, as well.
Dr. Hines,
so let me just
can I add something to your question to her?
Yes.
I have a grandson to be, will be born around November. And my daughter, who is a medical student as well, says that me and my wife, her grandmother, cannot even think about seeing this child without being vaccinated for COVID and also getting Tdap. Now, from my generation, I never heard of Tdap.
The relative, so on the newer, it's not new, but it's on the newer side of the recommendations for third trimester, all the adults in your lives, because you got a Tdap booster, and you want everybody around you because the adults are the harbor for pertussis. Basically, that's the short answer.
What is Tdap?
So Tdap is the vaccination for tetanus, diphtheria, and pertussis. And several years ago, they made a recommendation. They realized that adults are really the folks that are harboring pertussis, even if they're not necessarily showing symptoms of it. So they can be, when grandmas and grandpas and aunties and uncles come to kiss the beautiful new baby, they can inadvertently transmit the diseases. So the recommendation is to have Tdap boosters for the adults that are going to be in close contact with your newborns, as well as for mom too.
So can you take the Tdap at the same time that you get your vaccine or your booster, or does it have to be a separation? If you and Dr. Neighbor-Stephens could maybe address that.
I have seen no recommendation of a need for a separation of Tdap and vaccination against COVID-19, or for influenza for that matter.
So it can all be given at the same time?
I'm not saying all of those should be given at the same time. I'm saying specifically Tdap in any of those three.
Okay.
That is something that we need to really kind of toss around a little bit, is because the final recommendations haven't really come out yet. It is felt that it is safe to take the influenza vaccine and the COVID vaccine at the same time, but it is recommended that you space them out at least 2 weeks.
At the Kedron Center, where Dr. Jerry Abrahams works and where a number of us got our boosters a couple of weeks ago, they're wrapping them all into one injection.
Yep.
For good reason. You know, you can't trust people to come back.
And we've had folks on the Black Health Trust before that have talked about vaccine clinics of different types, some at schools where they've been vaccinating the children who are over 12 with the Pfizer vaccine, and also vaccinating their parents with multiple vaccines for exactly what you just said, Dr. Neighbor-Stephens, because that's where the people are. And you got, if I got a hold of you on a Thursday evening, let me see what I can do to generate an overall healthier community.
Yeah.
And
While we're on this topic,
that was the thought behind a change in policy several years ago now, utilizing emergency rooms as a point of care for immunizations. Because again, you couldn't say, well, you need to go see your primary care doctor and get this, that, or the other. They would administer them while they had their hands on you.
so let's talk about, I like what Dr. Walk started about dealing with health policy, but I'm also interested in these vaccines. So I heard some talk about health policy that because of the surge going on with Delta variant, that these people with these infections are crowding out people with non-COVID related medical problems. What should the policy be if you have not taken the vaccine and you get COVID? Should you be allowed to take up space in the emergency room from somebody with a heart attack? We've heard of stories last week of a gentleman where they tried 48 hospitals before they could find him an ICU bed, but he passed before he could get it. What are some thoughts that anybody has around the right to get sick from a disease that can be prevented and how that affects the general population? What should their policy be towards those people? I know that's a bit sticky, but. I'd like to hear.
Okay. Okay, I'm gonna jump into the pool and really make the water murky, okay? Because a lot of the illnesses that we're talking about that bring people to the emergency room, like those heart attacks, are also things that people can prevent. So I don't think it's as simple an answer as you got COVID, you didn't get vaccinated, you go to the back of the line. Because there are going to be folks that say, wait a minute, you're 300 pounds overweight, you eat cheeseburgers every day, you haven't been to the doctor in 10 years, you go to the back of the line. So I don't want to say that I have a simple answer. And like any good politician, which I'm not, I haven't decided what side of the argument I'm on. I'm just saying that the argument is a little bit more complicated. So I'll let Dr. Naybert-Stephens or Dr. Hines jump in on that one.
Very good.
I think it's a bigger question, actually. I agree 100%. I was having the exact same thought that you just enunciated, Dr. Walks. I do think that it is a much bigger question than what you posed, because we, in several places, have seen where the available healthcare facilities are maxed out, and they have done all they can. They've crammed as many in as they can, and they're maxed out. And so we are seeing a health system in crisis, because our health system is built around a physical model. When I say physical, I mean a FIS model that keeps the bed's capacity restricted to the point where they can assure profitability. And that is why we don't have nearly as many hospitals and beds as we used to, because they cease to be profitable, unlike other countries where there are a lot more beds that are not dependent on being filled to keep the hospital afloat. So what we are looking at now is a system issue, a capacity issue, but we are inching our way to an ethical issue of rationing care. And that's where it really is something that we need to start talking about, because if not now, could be another reason why there is a severe restriction on access to care, either because of availability or for money or for a number of ways that those restrictions can occur. But once they occur, then we're faced with this ethical dilemma, which this country, I will say, this is my opinion, this country has not done a real good job dealing with ethical issues ever. And so if we're talking about ethical issues around rationing of care, we need to really turn up the heat on that discussion, because we're a long way from being ready to make any kind of decisions.
Dr. Hines, water is warm, jump in.
So I would also cautiously enter this pool, but I would also say that, especially right now, we're talking about inequity in healthcare, even when we're not rationing care. So to a certain extent, if we were to move to a formalized rationing of care program, I think we would be hit even harder in that space than we are now, because that would mean that someone at some point, to your point, Dr. Naybert-Stephens, about it's going to become an ethical issue and it'll be individual decisions. In the same way that there's bias and things like that that exist that impact our ability to get the quality of care that we need, even when we know what the problem was, even when we know what the standards of care are. We, especially as a Black community in the United States, we have difficulty getting the same known standard of care. So I think that would be a dangerous road for the Black community in particular.
Let me respond to.
So hold on, Dr. Maxey. Dr. Maxey, before you respond, Dr. Lisa Kerwin-Dawes, one of our regular attendees, chimed in from Jamaica and put in the chat that some people who present with an MI have been vaccinated, and this is how they are presenting with COVID. So that murkies the water. Thank you, Dr. Lisa. That murkies the water even more, because when we think somebody is presenting with an MI, maybe that's their presentation of COVID, because as you said, Dr. Maxey, COVID can hit any part of us anytime. Go ahead.
You're correct. So my response, first of all, I agree with almost everybody, but let me give a little bit of background. The health industry is somewhere north of $2 trillion a year, give or take $1 trillion. That is being made in profits by certain individuals, corporations, not all of which are based in the US. So it is very important that be fed, that beast be fed. In order for that beast to be fed, a large segment of our community must be sick. And that generates the money to keep that empire going. To Ivan's point about the 300-pound person who gets the diseases that go downline from that, whether it be heart attack or what, many of these people live in so-called food deserts. And I guarantee you will find more obese people are actually malnourished, not necessarily from calories, but lack of quality food. And if you go to a pharmacy, a supermarket in South Central LA, or in certain areas of Brooklyn, the quality of food markedly differs from the neighborhoods that have Whole Foods or Beverly Hills, et cetera. So many of these people, I'll use the word iatrogenically, I'm using it incorrectly because it's not just caused by doctors, but in these food deserts, that's why you see these 300, 350-pound people who supposedly are eating off of EBT cards or anyway, they have no income. So we have a healthcare industry that requires you to be sick. You have a food industry that's making people sick. And then you have issues that creates chronic illness. But on the other hand, you have COVID, which is more of an acute illness. So we know structural racism affects both of those. So I would err on the side that we know this COVID is an acute, common sense, avoidable illness, but you living in a food desert created by the industry needing to be sick are two different levels. So the present emergency, you need to get the vaccine. But also our other job here in the Black Health Trust is to remind people that you have to eat better, you have to take vitamins, you have to get exercise, Dr. Walks, and all of those things, we have to defend ourselves. And in order for a successful army to be developed, you have to get physically fit. You have to walk, you have to march, you have to run and get ready, and you have to eat right. So I'm putting this as a war against bad health and death in our communities. And the only immediate emergency is COVID, but the regular things, diabetes, obesity, hypertension, and all these other things have been with us all along. We need to get rid of those too. So I think that we do have to prioritize an immediate emergency while not ignoring the continuing problems with obesity, bad health, bad nutrition, and most of all, a certain amount of ignorance about health. So hopefully we've helped people deal with how to eat, how to exercise, and we got to get that exercise guy back, Mr. Palmer. Anyway, that's my spiel for the moment until.
So Dr. Maxey, I'm gonna let Dr. Neighbor-Stevens and Dr. Hines beat me up when I say this. I think very often, first of all, everything you said makes perfect sense to me. And at the same time, as someone who used to live off of 39th and Western, right on Middleton Place in South Central LA, and who's been in a number of other communities. When we make generalizations about our community, the one thing I want to make sure we don't do is I want to make sure we don't forget about or discourage that person in whatever community they're in who is exercising every day, who is looking for food that is healthy, and who isn't willing to count themselves among the number of folks who can't find a positive way out and can't find a good way out. The policy folks that Dr. Hines leads as the head of her organization, and many of the other people, are working on the policies and working to make the community better. All of that is going on. And at the same time, I am going to continue to cheer for those folks who find a way to break whatever the system of we need you to be sick and the system of we need you to do this. Those people who find a way through, we all are cheering for them and hoping that they can be examples in whatever community they're in. That's all I have on that.
I agree with that. Before you get beat up, though, let me just say 39th Street is pretty close to the good neighborhood, though.
Really? I'm gonna take you back on 39th.
Dr. Neighbor Stevens, what's going on?
Well, a number of thoughts, but the one I think I want to bring forward at this time is something that you all know is a real pet peeve of mine, which is I get weary pretty quickly of a lot of talk that doesn't lead to action. And we have been on the air now for several minutes, and I don't feel that we have done what we need to do in terms of encouraging and empowering our audience to take control of the situations that they find themselves in or that we find ourselves in, and have conversation and planning around what we can actually do. I think that there's been a lot of opinions shared and aired, but I don't hear us in any way leading a conversation that will be productive of action.
Well, start us off.
Well, I think where we start is at a local level, and we have got to take control of the outcomes of our elections. And once we get people elected, we've got to hold them accountable to do the things that we have identified as being needed in our communities, and expand that same concept up from local to state to federal. Because right now, where we are dangerously near, if not there, is gridlock, where nothing is going to get done. Or what does get done is so compromised, the worth of it is questionable.
Can you explain a bit more what you mean by gridlock and where you're going with that?
Well, on the local level, where depending on your state, and for me, I live in Florida and Tennessee, and in both states, they got the same issue of local and state level officials playing to the tune of the parties that they belong to, and in a lot of instances, totally ignoring what the citizens in the local communities really want. On the federal level, we've got a Senate and a House that have razor thin majorities, and even in those razor thin majorities, so much infighting is going on that the result of any of the bills, when they get through the process of making bills, a lot of the things that people were really interested in may not even be there. Now, we all were I shouldn't say that, that's a generalization. Many of us were very excited about the thought that we would see some free community colleges come out, changes in health coverage come out, increase in food stamp budgets, which hadn't been raised in years, come out. There are a number of legislative things that we were very hopeful would come out. But when they get through compromising and twisting arms and stuff, it's going to be very interesting to see what survives once it comes out, and even more interesting to see whether or not it gets passed.
So what does this mean to individuals on this type of call?
It means track people, track the actions of the people that you vote for and hold them accountable the next time an election is coming up.
That's a real good point. So at the bottom of everything in every country is the political side. But I don't believe we are unilateral or on one side or the other. How can we affect that change, Dr. Napier, or anybody on the call? How can we affect that in a non-platitudinous way? What can we do? What can individuals on this call do? What can we do as a group? How would we address some of that?
I don't want to keep talking, so please, one of the other co-moderators.
Well, I think, let me just say this about that, but there's also something else that I want us to get back to before we get too far away from it. But we have talked about policy issues. We've talked about having folks who are elected officials on the Black Health Trust, and we've had folks at different levels of government come and speak on the Black Health Trust. So we can certainly keep an eye on things and advocate for things that make sense. Dr. Nabor-Stevens just mentioned some of those. So I think that within our individual communities, we can continue to bring these questions forward. Certainly whatever questions are in the chat, there's one in there, actually Dr. Hines put in the chat, do you know who your local elected officials are? So there, a lot of times people don't know. And in places like Washington, D.C., for example, there are so many levels of elected officials. There aren't only the mayor and the city council, but there are ANC commissioners that are elected. So there's a lot of opportunity to just be aware and to get to know the folks who are running. Can I switch us for just a minute? Because Dr. Hines said something earlier about teaching her kids clam hands and what clam hands mean when they go out. And I wanted to make sure that we didn't get too far away from practical because I've never heard of teaching kids about clam hands. And I think it's a wonderful idea. Dr. Hines, can you tell us a little bit more about that?
Sure, and then I'll do that in just a second, but I also, what I also put in the chat was a website where you can put in your address and your zip code, and it'll tell you who your local representatives are. It'll tell you who your state, your House representatives. It might have your county representatives, because the first step is, who are those people, such that if you do need, if you're going to track a record, if you're going to send a letter, make a phone call, you need to know who the people are. So I put that in the chat. But as far as other practical tips, for example, for the kids who cannot be vaccinated, several of the things that we've done. So clam hands is essentially, I tell the kids to cross their fingers, lock them up. And usually that happens when if we have to go somewhere like to Target and we're at the checkout station, you know, those places that kids naturally want to touch things, clam hands, right? And we've done it enough that they know what it means. I have little portable hand sanitizers on their book bags. I have them on their bicycles, so that if they're, and my kids are little, so those are probably the only few places where they're kind of out of my reach. Obviously, I have some in my purse. I keep handy wipes in the car, because lots of people are doing a lot of on the run eating and those kinds of things. That way we can get the hand sanitizer in before, while we're in the car before we eat. Because again, kids are oftentimes, they're on the move, they're hungry. I want a snack, right? They're so fast to put whatever they've touched right into their mouths without a thought of of a germ or dirt even. So those are some of the things that we've done. I've tried to make a point to get them masks that they like, so that then it's less of a struggle for them to wear them. It's a little bit more time consuming, but at least it allows them to wear them more consistently because they like, my son is a Avengers kind of guy. So he's got the Hulk and, you know, Iron Man, and my daughter is much more into the little version of Black Girl Magic. So she has a lot of little, you know, I'm smart, I'm gifted, I'm talented kinds of masks. She likes to wear them. They're empowering to her too. It's a win-win for everybody. So we're planning a trip to Mississippi. Because it's funny, we were talking about Mississippi earlier. I'm based in Maryland. I'm not super duper excited about taking my unvaccinated children on a plane to Mississippi, but it is my grandmother's 100th birthday, and that's not happening again. So we're going. But what that means for us practically is I'm going to take every reasonable precaution that we can. Like, I got the kids, you know, obviously they have their masks, but I also got them some face shields to wear while they're on the plane. I already know that my son is not going to tolerate the headband kind, so we got him the glasses kind, because I'm not going to set him up to be unsuccessful on the plane.
So tell me how you're going to protect grandma.
So how we're going to protect grandma is vaccinated, and how we're going to protect, now I will say this caused family strife. I'll be honest with you, because some members of the family wanted to do it the same way we would have done it if there was not a pandemic. And as you can, other members of the family are not on board with that plan, especially in the context of where Mississippi as a state is with regard to its COVID infection numbers. So how we are ultimately planning to protect grandma is to have a more distanced gathering, kind of like the drive-by scenario, instead of a bunch of people potentially giving her the kiss of death. So we'll wave, we'll drop our gifts off. We're not going to have the classic banquet style event that people would, you know, probably might expect for that, because it doesn't make sense. But at the same time, we can still honor the fact that you've reached this tremendous milestone. We can still honor your life, you know, and give you your roses while you're still here, kind of thing. But we don't have to do it in a way that becomes a COVID outbreak.
So good. While we're on this point, let's talk a minute about the topic of boosters. That's been in the news recently, and there were some decisions made. Would you like to talk about that, you or Dr. Nabet or Dr. Walks?
Well, I'm glad you interjected that, because I think we need to start at the beginning of this whole conversation, which is with the initial dose, based on the question I've just seen in the chat. So we know that we have a choice of 3 different vaccine products, 2 of which require 2 doses and 1 of which requires 1 dose. The goal of the vaccine is to protect you from serious illness. We have said on multiple occasions that the vaccines do not prevent infection. You may not have symptoms when you're infected, but they don't prevent 100% infection. What they do very, very well is, if you do get infected, prevent you from getting very serious illness. The reason I'm starting there is because the question in the chat was, can you explain why we're seeing so many breakthrough infections? And that is another example of how we have not messaged very well what is going on. These are not breakthrough infections. They are infections that have occurred not unexpectedly, and they are almost 100% doing what they said they were going to do, which is to prevent serious infections. When you listen to the interviews of all of these hospital executives, as well as if you look at the actual stats when they release them, of the people who get hospitalized and wind up in the ICU and on the vents, close to 100% of them are unvaccinated.
Let's go back to the word breakthrough. And there's a little bit of controversy about the actual meaning of that word. Explain that just a little bit deeper and make it understandable. Breakthrough versus original infection, decipher that.
A breakthrough infection is a term that's being thrown around, indicating that someone who is fully vaccinated comes down with COVID. And the connotation of it is, and I can't speak to how it is portrayed in social media. I'll leave that to Dr. Hines or somebody who's trolling in the social media space. But in the general conversation, the connotation is that this infection broke through the protection of the vaccine. And that's why I said that we've done a really poor job in messaging in the first place.
Have we done a poor job, or the media?
Yes, I think all of us need to own piece of it. Because the reason I say we all own it, I did my best to make it clear, to have clear understanding of expectation of the vaccines. Whenever anybody said, you know, you needed to get your vaccine to protect yourself, the question is, protect me from what? And we have not done a good enough job of getting that message out. What is the vaccine protecting you against?
So what you're saying, if I interpret you right, this is not a breakthrough infection, but a new infection. Is that correct?
Yeah, it's a new infection.
Okay.
It's somebody who is fully vaccinated.
Right. So it's not breakthrough, it's a new infection, and the vaccine will protect you or mitigate the level of sickness or illness you get from that new infection, and
Correct.
probably protect you from being very sick or dying.
Yes.
Okay. And we also know that the vaccines are somewhat around 95% efficacious. That means that they're 5% potentially unefficacious, and that 5% of a large number is still a number of people who may have a vaccine and it not necessarily protect them. Is that correct?
I would disagree. I was just about to ask you to define what your 5% efficacious of what? The promise of the vaccine is to keep you from having significant illness.
No.
Yes,
what
that
I'm
was
saying,
the endpoint of all the studies.
no.
And I will defer to Dr. Walks, the head of our task force, to speak to this.
The 95% efficacious means that in 95% of persons, it will potentially prevent you from getting an infection. In 5%, it may not work. So if you use that 5% number as those who are unprotected, that's what the word efficacious means.
Okay, so let me just, one of the reasons why I consistently say I need to understand things very simply is what has been happening with information about the vaccines. Yes, I did chair the Black Health Trust Vaccine Subcommittee. We took the information from the FDA and from the National Medical Association. We talked with the executive director of the American Public Health Association, who was on our task force. We talked with the head of the National Medical Association. We did all of that. We talked about how the vaccines were made and the fact that there are people that look like us. We talked a lot about Dr. Kizzmekia Corbett and all of that, all with this notion that we wanted to make sure that we could give people advice that they should get the vaccine. So glad that Chris Rock is on board. Love Chris Rock. Yes, people should get the vaccine. All of that is true. Now, as an individual person, the 95%, the 5%, all of that is very interesting. Let me just tell you the way I understand it. It's better for me if I get the vaccine. There's less chance of me getting COVID and dying if I get the vaccine. There's almost no chance that the vaccine is going to make me very sick. I may get pain in my arm and I may not feel well for a day or two, but there's almost no chance that the vaccine is going to do something bad to me. There's a big chance that COVID may do something bad for me, so I'm going to get the vaccine. Booster shots. The FDA panel just advised, no, everybody does not need a booster. But if you're immunocompromised or you're over 65, you should get the booster. And the time frame, as I understand it, is 6 months after you completed your initial booster shot. Then I read something about, well, the Moderna vaccine is a little bit better at protecting you longer term than the Pfizer vaccine. I read that. All of that is interesting. What I take away from all of it is this: the fact that I am fully vaccinated now does not mean that I cannot get COVID. It means, as Dr. Maxey said, that I have a much higher chance that if I get it, I'm going to have a really, really good outcome, and I'm not going to get really sick, and I'm not going to die. And if I take the vaccine, almost no chance I'm going to get sick from the vaccine. I don't know what else anybody needs to know to get vaccinated, except for the fact that hundreds of millions of doses have been given out, and people are still taking the vaccine, and people are still being protected. And I think that takes us to some of the social media issues that we have, where folks talk about, well, I read this on media, and Nicki Minaj is posting stuff about somebody she knows that had this up. All of that is fabulous and fine. You can read all of it. The bottom line is, and I'm going to have to defer to Dr. Hines because she's the doing all the health statistical stuff and understands all that. All I know is statistics have very little utility for me as the individual, because I might be that 1 in a million who does this, or that 1 in 1,000 who does that. So for me, I'll say for the last time, almost no chance the vaccine is going to hurt me. Really, really good chance it'll protect me from COVID. I'm getting the vaccine. As soon as a booster is available, I'm going to get a booster. Why? Very little chance the booster is going to hurt me. Good chance it may help a little bit in protecting me further, because all the conversations about the booster aren't the booster might hurt you. The conversations are, do we really need the booster? Not if you take the booster, it's going to hurt you. So got my vaccine, going to get my booster when I can. That's what I can tell you. Dr. Hines, any statistical reason why I'm totally wrong, or just wrong just in general?
No, there is no statistical reason why you're wrong, or that you're wrong in general. I do think, though, that I think that the kind of the point that Dr. Nabert Stevens was bringing up earlier is about the discrepancy maybe in lay people's understandings of what a vaccine is supposed to do and the assumptions that are made there. So for example, when I get my measles, mumps, and rubella vaccination, I don't ever expect at all, 0%, to get measles, mumps, or rubella, right? So there are lots of people who, lay people now, who assume that the whole reason I'm getting a vaccination is to keep me from getting the disease. That's their interpretation. That's their expectation. If I get a hepatitis B vaccination, I'm not supposed to get hepatitis B at all. Like, that's the framework from where people are coming from. Yeah. So the part where I'm not supposed to get severely ill, that part's kind of lost in the message, right? Because that's not their understanding of what a vaccine is supposed to do. And I think it's also very hard for people to conceptualize 1 in a million, because 1 in a million is worse than my chance. Like, that's worse than my chance of winning the lottery. And I've never, ever won the lottery. So then that's not something that's going to affect me, right? From a math point of view, you recognize that if 70, I forgot, I typed it up and left it. If 70 million people are getting the disease, 1 in a million has a different significance than when you're talking about other people's frame of reference for those kind of broad numbers and broad statistics. The average person doesn't have a way to conceptualize what that means. So lots of people interpret that as 1 in a million is next to never. So why would it very well may seem like and feel like, why am I taking this so-called risk over this thing that could 1 in a million never happen to me? Now, I will also say that at this point, in the news, and as you pointed out earlier, at this point, pretty much everybody knows somebody, at least in the United States, with the 1 in 478, I think you said, Black people. Somebody knows somebody that's died from COVID, right? So at this point, now it isn't that it could never happen. Now I think we are challenged with a different understanding of what's supposed to happen now. Like, where is my vulnerability now? And I think that some of the statistics that we share with lay people don't have the same value, like 95, but then you said I was supposed to be fine. So why am I fooling around with you folks? Because the rules keep changing. Like, it is confusing for the average person to understand how science works, that science is ever evolving, that new information comes out and we have to change our position on things. That again is not where most people's fund of knowledge comes from. It goes, a fact is fact, 2 is 4, it's always 4, 2 is 4. And I think that this really tests people's ability to be flexible with their interpretations of how to intake information that they're unfamiliar with.
Good, good, good.
Agreed.
So let me see if I can just summarize a minute. What we do know that we've transmitted here on the Black Health Trust is that we recommend that everybody get the vaccine. It definitely beats dying, and we know that 99% of those who are hospitalized and are dying come from the group that is unvaccinated. I think we pretty much 100% agree upon that. In addition, we do agree with the current advice that many people are going to need a booster. And right now that has been given as a positive sign to those who are 65, I think was the number, and over, and those who may be immunocompromised in some way, which includes obesity, diabetes, and a number of things that we mentioned before. Are we all on board with that?
Yes.
Okay. Now, we're also saying, and I think we agree, that taking care of your individual health at the level of reducing your risk factors, which we know are low vitamin D, obesity, high blood pressure, and a number of things. And we think that the more you reduce those risk factors, the better off you are in terms of dying in any case from any other thing, and add exercise to that as well. And I think we all pretty much agree upon that. What I also think I heard our moderators say is that the nuances of communication sometimes lead to words that don't convey what's really meant, like the word breakthrough. Is somebody really having a breakthrough? In order to break through, it means you had something pre-existing that broke through a barrier. And I think what we're saying, that these breakthroughs are not really breakthroughs, but they are new infections that can still be mitigated by the vaccine. Is that a correct, something we agree upon?
Yes.
Okay. So I think we're mostly on board with all of that. Now, we also know that all of us on this call, both guests and moderators, we spend a lot of time pouring through journals, looking at news, conversing with each other, trying to be up on what we call vetted information. Now, every week I get stuff from all kinds of people with tin hats on, and those are not the ones that I read other than to know how people are trying to mislead our people. But we try to present the things that we agree upon that mainstream medicine believes can help you. That's why we don't recommend things such as ivermectin, hydroxychloroquine, and a number of other things that may someday maybe end up being the correct treatment, but as of now, science, as we see it, does not recommend those. I think we agree at this point on that. Now, on our Wednesday night calls with our medical advisory, we're free to talk about all of those things. and we can battle it out, but what we present as our joint position on Sunday are the things that mainstream medicine, real doctors agree upon. Now, there's some things that we may have difference of opinion. We're not going to present those until we come to an opinion, and it's not just an opinion, but we've done study on that. I think we agree upon that. What we present is something that you can trust. And when something we put out last week changes in science, we'll talk about it next week in the new light. And I was very proud of Dr. Fauci today. He had suggested that boosters were absolutely necessary for everybody. The committee decided that it was needed right now for older people over 65 and those who are immunocompromised. And he said he would accept that, but he thinks ultimately it will be generally accepted for the general population. So he was flexible enough to understand how science works. And it is a group think, not just individual, not just what Maxie thinks, neighbor thinks, Walks or Hines think, but something that we can come to an agreement on as our best position. Are there any questions in the chat that we need to address?
There are a couple of questions in the chat regarding monoclonal antibodies, and I was going to wonder if Dr. Nabrit Stevens could put in the chat the
Dr. Hines has already
reference.
done it. She's taking care of it.
Well, okay. For
Well,
those who
what
might
I
not be able to read,
was going to say,
speak to it.
what I was going to say is put in the information about how to get to the website that we had put in a couple of weeks ago, if we still have that.
Yeah. Don't presume everybody can read the chat. Can you answer the question live?
So the question was monoclonal antibodies versus vaccines. And I simply said monoclonal antibodies are used as a one-time treatment for COVID illness. And it doesn't provide any long-lasting or long-term immunity or long-term protection versus vaccination, which is designed to prevent severe COVID illness and does provide a longer term immunological protection. And I can say longer term because obviously the jury is still out on how long that term is.
Okay,
But
so after
One is
obtaining a monoclonal antibody, it is still recommended that at an appropriate time that you become vaccinated. Is that true?
Yes.
Absolutely.
Okay.
So before we leave that, let me also add to what Dr. Hines said. This possible assumption that maybe I can wait till I get sick and get monoclonal antibodies, that's a big presumption that you can get the monoclonal antibodies when you want to. So Dr. Nabrit Stevens did a couple of very good presentations on monoclonal antibodies, and still there's no guarantee that you can go down to your local, wherever you want to go, and get monoclonals because you tested positive for COVID this week and you have some symptoms and I need some monoclonal antibodies within the next 2 or 3 days now. There's no guarantee that that's going to happen. So I want to be very clear that waiting until you get sick and going to get monoclonal antibodies, I don't think that's a good strategy. Maybe I'm wrong.
No, you're correct. And also let me say this, those same governors in those same red states that are telling people don't get the vaccine, but get the monoclonal antibody. To me, that is simply pure politics and they don't care what happens to the people. If you're afraid of the vaccine, why aren't you afraid of the monoclonal antibody? So that's political. It has nothing to do with good health, nothing to do with good recommendations. And Dr. Walks is exactly right. I've sent people for monoclonal antibodies and that people want to charge them $2,000 or whatever price they can rip off. And unless you go to the right place, you may or may not get it at the time you need it. And if you wait more than 10 days, I think it's not recommended. Is that correct?
Correct.
Okay. So very good. We got a lot of agreement here. What's going on? We need some controversy. Any other things in the chat that we need to deal with? And any comments, any questions that anybody has? I encourage you to put them in the chat or raise your hand.
There's a question in the chat about vaccinated children who tested positive. My stepdaughter, who was vaccinated, children tested positive for COVID, and then she tested positive. Her physician recommended monoclonal antibodies. She has asthma. What's your opinion? And I think the question is, if you have asthma, could you still go and get the monoclonal antibodies?
Yes.
And you should. In fact, there's a chief of anesthesiology on the phone from a university, I believe, in Virginia, and an anesthesiologist is somewhat of a pulmonologist, Dr. Coombs. Can you unmute yourself and maybe address that and speak on that issue a little bit? Simon, do you see?
Thank you. Yeah, thank you, Dr. Maxey. I'm sorry I missed one of the points because I just stepped aside for a second. Can you just tell me what the question was?
Dr. Walks?
Hi, Dr. Coombs. The question was about if someone has asthma and they have tested positive for COVID, can they still get the monoclonal antibodies?
Yes. Yes, we have patients both in our MRICU and several of our other units who have reactive airways disease, and yes, they can get the monoclonal antibody. Thanks for asking that question.
So, and let me give you a couple of propers. Was there a rather prominent medical journal that you were the chairman of, the president of the group that puts that together? Dr. Coombs?
I'm sorry, I was having trouble unmuting myself. Yes, I was the president of the Mass Medical Society, which owns the New England Journal of Medicine. You know, I know there's been a lot of literature lately regarding monoclonal antibodies, but that there is a firewall between the organization and the publishing division.
Okay, but you were still overall in charge. I'm going to give you that credit anyway.
And Dr. Maxey, thank you so much, Dr. Coombs. And Dr. Maxey, one of the issues we've talked about, you talked about the cost of monoclonal antibodies, and Dr. Kerwin Dawes had a comment in the chat about availability in different places. And because our audience is not only national, but international, maybe Dr. Kerwin Dawes can speak to us a little bit about the challenges that they have getting the monoclonal treatment.
That would be perfect. Can you speak like a Bostonian instead of a Jamaican, though?
Don't ask her to do that.
Dr. Dawes?
I don't know if I can do that, but presently we were out of monoclonal antibodies in the island for a good 2 weeks. So we do have a lot of difficulty getting this. I am actually off today, and I got 3 calls about where do I know anywhere where we can get some for some sick patients, for some patients right now. There was a comment I wanted to make earlier. I don't know if you guys are seeing that in the US, but we are seeing a number of people coming in for MIs, unstable angina, DVTs, who have been vaccinated, who are now presenting with COVID. So just saying they're not being treated, I think it's stressing out everybody at the hospital, because when they come in now, the staff, having had a few people convert on the wards and finding out they were positive while treating them for MIs, they want to put everybody in where they're ruling out for COVID until the test is back when they come in for MI, of course, which don't make families happy, or an exacerbation of CCF. I think I had 2 yesterday from our ward that came in with exacerbations of CCF. who are vaccinated, by the way, they were vaccinated not with Pfizer, with AstraZeneca. We have Pfizer here now and J&J, and that was their presentation. So we can't actually say not treat them or not give them care, because now that they're coming in for our MI or our asthma exacerbations are up. And one of the first guidelines I put in when we weren't able to actually swab everybody, and we're still having difficulties with that, that certain, like all of our sicklers that are coming in with exacerbations have to be swabbed. A number of them are presenting that way with COVID. As some of the sicklers are young, so they're not vaccinated. But a lot of other things, because of the hypercoagulability, will present that way, and they do have COVID, whether they're vaccinated or not. So we just have to try to find space to treat everybody. That's how I look at it. And
Yeah.
we're still encouraging everybody to get vaccinated.
Yeah, I think you're correct. And at the beginning of the program, I raised the question more at starting controversy than what I believe. But we do need to treat everybody. But I think we also owe it to ourselves and to families, when we take everybody, to also presume that they may be infected during the pandemic. And because even health professionals and other patients need to be protected. So I appreciate your input on that.
Dr.
I have a question, though, that maybe you can help out, that we were discussing on our own policy. If you have, which has happened 2 days ago, a member of staff, a nurse, who is fully vaccinated, her daughter, who is a teenager, is now positive in the house. The question that comes up is, now she's vaccinated, when should she be allowed to come back to work? She's asymptomatic, and if you swab her and it becomes positive, it makes it maybe easier. But even if she is negative, how much time off, or should she be allowed to just go ahead and continue treating patients? We were debating.
Interesting. That sounds like a question for a director of healthcare for Washington, D.C. Is that in your area, Dr. Walks?
Is that in my area? No, that is not in my area. I am not the current director of health for Washington, D.C. That is a previous time.
I was the person that was called about this yesterday.
I think I might be able to help you on this one.
Go ahead, Dr. Hines.
So the current CDC recommendations for vaccinated healthcare workers who are exposed to who are exposed to and have extreme significant close contact with folks who are positive is that they should get tested 3 to 5 days from that exposure. So the good thing about it being a teenager is hopefully they can do a degree of quarantining with the teenager. As an asymptomatic person, you could take two routes, right? The guidance says that outside of the significant exposure, and they give some examples of significant exposure that are specific to a healthcare setting, but in a home, you can think of significant exposure as, you were in each other's faces, people who you might be kissing, swapping saliva, those kinds of things. You could say 3 to 5 days, get the negative test. As long as she's asymptomatic, she could return to work in that capacity. If she was not able to, for example, if it's an infant or a younger kid who you can't actually quarantine from, or you can't not have significant ongoing contact, significant contact with, for example, a 2-year-old or something like that, they're going to be in your face. That way I would treat that a little bit differently than someone who can actually quarantine. Therefore, generally, asymptomatic people don't have to go. Asymptomatic vaccinated healthcare workers, and the CDC has a whole separate page for the healthcare worker guidelines. In general, vaccinated healthcare workers don't have to be removed as long as they are asymptomatic, with the exception of people who have the significant contact.
Okay, now, let me ask a further question on that. We know that vaccinated, asymptomatic people can also harbor and transmit variants. Is that correct? And if that is true, how would that affect when that lady does go back to work? Should she be wearing a mask? Should she distance? What would you expect? What would the guidance say about her situation?
The guidance remains for healthcare workers to continue to be masked and use PPE consistently. I think the reason why the healthcare worker language is different than the layperson language is because it acknowledges that you can't take all the healthcare workers out of work. So I would imagine that it is written that way so that you can still have some people who are able to be part of the workforce, because if everyone who was potentially exposed to COVID can't go to work, then no one's at work.
I think it's special, especially for the work people. I had an incident, and just while we're on this call, a couple of weeks ago. Our social cases, before they're placed in infirmaries, are usually swabbed, and as they come in, they get consent and they're vaccinated, and they're swabbed again just before we're going to vaccinate. The social cases that were swabbed a few weeks ago were all negative and kept in a certain area. We have now re-swabbed them last week, and a quarter of them are now COVID positive. The staff that took care of them, we're now reprocessing and doing the staff. We've now found that 2 of the staff are asymptomatic, but COVID. So now it hasn't become a big thing on how we're going to deal with that and prevent this from happening in the future. So any help, because I'm one of the committee, I'm part of the committee, I'm head of infection control for our hospital and our county. So that sets up the advice. So we look abroad and look what's opening locally and try to come up on what best we can do.
Yeah, and I think Dr. Kurmandaws, the advice that Dr. Hines read from the CDC is going to be our best scientific advice.
Thing for now.
Absolutely.
And I posted a link to it in the chat, to the overall that section from the CDC section. I put it in the chat.
And the staff all have to be masked in Jamaica. Everybody that comes in has to be geared for all patients. That's a continuous, because we presume everybody can be positive. We are just trying to figure out how to prevent this from in future, because the social patients are kept in an area and they are not moved out of the hospital that quickly. And we don't want to get in trouble that you're positive and now you're negative and now you're positive, that you definitely got it from us. So we're trying to look at both ways, legal as well as medical. That's why I asked the question.
Well, thank you so much. And we're about at our allotted time. Are there any final questions in the chat we need to address?
There was a request for clarification from Marie Doc Holiday, and I'm looking to see if Doc, if you're still on.
And I like that name, Doc Holliday. He was one of my heroes, right? And with Wyatt Earp.
Dr. Maxey, you are way too young to know anything about Doc Holliday and Wyatt Earp.
I like them.
Excellent. So does she need clarification on an issue?
I think that I messed up some of the pronouns in her question that was in the chat. And so she wanted to clarify her question, but I don't see her. She may have had an internet interruption or something like that.
Okay, then let's let our newest addition to our team, Dr. Hines, have a final word, followed by Dr. Walks, who may speak of a special relationship, and then Dr. Neighbor Stevens and myself.
So I just want to thank everyone for your time today. We had a very good discussion. The questions in the chat were great, and just bringing in some really good real world details and real world examples of some of the questions that you have around how to live and manage this, in this pandemic time. So I just thank you for letting me join you, and looking forward to seeing you all again.
Yeah, my comment, Dr. Maxey, would be that I'm really happy that we have Dr. Hines. I think that fresher perspective is there. My number one comment is Dr. Hines is one of those people who's able to read the chat and talk and chew gum and all that at the same time, and that speaks to the skills of youth. So I think it's a great thing to have Dr. Hines be added to our group, and I'm looking forward to other contributions from her as we go forward. And that's all I have to say about that.
Dr. Walks, you seem reasonably obsessed with AIDS and AIDS gaps. We have to talk about that sometime.
Dr. Maxey, it's just me looking in the mirror every day.
Dr. Neighbor Stevens.
Well, to that point, Dr. Walks, I'll just say the fact that you were up looking at yourself in the mirror is all you need to worry about.
So is that something along the statement, it's better to be seen than to be viewed?
Yeah, that's right. I think that the takeaway this week is the same as we always have, which is to be safe by using common sense. I would just add that it strikes me, I've been kind of musing to myself, and maybe this is a function of my age, and I'm reflective of it since I had a significant birthday this week. Well, all birthdays are significant, but it just strikes me as weird. So that's why I'm saying I think this is a function of my age. It just strikes me as weird that people look to rap stars or athletes or entertainers or anybody else for their health advice. It just, and I don't think that's because I'm a physician. I think it strikes me as weird as I think you use common sense in who you go to get advice. So I've been really wrestling with myself this week, trying to get over whatever my biases are and whatever the brick wall is that's preventing me from understanding what's going on in this country. I beseech you to get your information from bona fide experts. Read it, validate it before you just take the word of someone just because they happen to be famous.
Well, thank you so much, Dr. Neighbor Stevens, and I'd like to join all of us in thanking and welcoming Dr. Hines to our group and appreciate everything you're bringing to the table. I'm going to remind all the professionals on the call that we will be having a meeting of our medical advisory on Wednesday at 5 o'clock Pacific, which is 8 o'clock Eastern, and I think that must be 6 o'clock Central. Is that correct?
7 o'clock Central.
7 o'clock Central. Okay, and we have several interesting speakers, and I invite you all to join as usual. And we thank our listening audience. And if there are questions you have, you can send them during the week. We are streaming live, not live, but we're streaming on Facebook, YouTube, and a couple of other things. And we will be advancing our format coming up. So I thank everybody for attending. I thank Ms. Yakini Stevens, and I thank Mr. Simon Cooper for their technical and intellectual support of this broadcast. Have a good day, everybody.
Oh, Dr. Maxey, Reverend Pointer is on.
Oh, I'm so sorry. In fact, when Barbara used the word beseech, that put him right in my mind. So I beseech Pastor Pointer to give us our final words.
Good afternoon. Thank you all. I appreciate your prayers as pastoral duties have claimed me the last couple of weeks. And actually, when I leave here today, keep in prayer Mother Bertha Hassan, 91 years old, and has decided that it's time for her to decrease. So keep her family in prayer. And keep me in prayer because for a few decades, she and her husband have been an incredible gift to the body of Christ and to me personally as a pastor. I wish that things were different, but God knows what He's doing. So I'm going to be grateful for the time that we've shared. It is a blessing to see you all. Dr. Hines, your presentation was incredible. I actually called a couple of parents and said, if you're not busy now, I need you to get on the Black Health Trust. And I'll be referring others to the video in the archives. Thank you so much, and we'll continue to cover you in the work that God has given you. Let me share with you this prayer that written so that we might hear ourselves again around our head. Let us pray. God of our salvation, our rescue, our help. All things are yours, and when we bring our hearts and hands and voices to worship, we bring you what is yours. Yet we do not serve you as we should, and the world is racked by all the tensions and outright conflicts which come from the worship of that which is less than yourself. Our goodwill towards men has no firm foundation and crumbles at the first tremor of real testing. In our personal affairs and in our communal judgments, we try to heal deep wounds with superficial cures. Father, our prayer is, forgive us. Confront us with your way of righting wrong, your strange work of redemption through the sacrificial love of Jesus, and help us. Help us to love one another as Jesus has loved us. This, O God, is our prayer. Amen.
Amen.
Have a good day, everybody. Thanks.
Bye,
Bye.
everyone.